Okay, sir, now I will hand over the mic to start this presentation.
Good morning, everyone. My topic is surgical audit of manual small incision cataract surgery done by final year junior residents. As far as phacoemulsification and small incision cataract surgery is concerned, small incision cataract surgery is economical and non-machine dependent, and the visual outcome and complication rates are similar in both the surgeries. So it is important for all postgraduate trainees to be trained in SICS to combat the large volume of cataract blindness in our country. This was a prospective observational study carried out on 858 eyes of 611 patients. All the patients had uncomplicated senile cataract. Routine preoperative evaluation along with astigmatism assessment was done. Post-operative assessment was done at the end of 6th week, and surgically induced astigmatism was calculated by SIA calculator. SICS was done by standard surgical technique under peribulbar anesthesia. Majority of the patients were males and right eye was predominantly involved. About 72% of the patients had a preoperative best corrected visual acuity of 6/36 or less. This improved to about 91% of the patients having best corrected visual acuity of 6/12 or more. Common intraoperative complications were capsular excess extension, posterior capsular rent, premature scleral corneal tunnel, iris prolapse. Common postoperative complications included corneal edema, anterior uveitis, and hyphema. About 60% of the patients had a astigmatism of less than 1 diopter, and about 25% had between 1 to 2 diopters. So combining these two, about 85% of the patient had a astigmatism of less than 2 diopters. Subudhi et al. Reported a mean pre-op uncorrected visual acuity of 6/120 and post-op uncorrected visual acuity of 20/50 in a series of 339 eyes. Intraoperative complications were tunnel-related, iris prolapse, capsular excess problems, PCR, and post-operative complications were corneal edema, shallow AC, updrawn pupil, and residual cortex. Nayak et al. Reported complications in a series of 293 eyes. He reported 14% had buttonholing or premature entry, and another 12% had a PCR. In his series, 63% of patients had a post-op visual acuity of 6/12. So in our study, the surgically induced astigmatism was 1.3 diopters. To the best of our knowledge, after PubMed search, this is the first study assessing surgical induced astigmatism by final year residents. A couple of studies which I have discussed have published visual outcome and surgical complications, but they have not included astigmatism as their parameter. This is important because it affects the quality of life of the patients. Moreover, these residents would be doing surgeries independently after passing out. So astigmatism is a very important area which should be addressed during training. To emphasize, we want to conclude with systematic stepwise training of residents in the first 2 years can lead to good visual outcome and low complication rate. It also leads to standard post-operative astigmatism. And I want to contribute the acknowledgement of all the faculty, senior residents, optometrists, and nursing staff of my department. These are my references. Thank you.
Thank you, Dr. Sanjay.
Did your study include any data about the nature of cataract?
They
were
there,
simple
but
cataracts.
I have not included because the number of slides and time constraint. That is routinely done assessment, different types of cataract. But usually we give residents not very difficult cataracts, not very hard cataracts.
Okay, so
grade 2 or
simple
grade
cataracts.
3.
Okay, okay, fine.
Was there no lens drop intraoperative?
Sir, this is a final year resident, and we first teach the steps in the first 2 years, and that is why I said only this data is for the final year. And in the first 2 years, we teach them step by
But
step.
for final year students also, amongst these 800, no lens drop.
No, because it was being monitored by the surgeon on the TV monitor. Any complication was taken over by the consultant. There was no lens drop in the final year, sir.
Excellent.
Excluded the lens drop cases.
No, I have not excluded. In the final year, there were no lens drop.
Not a single case.
No.
Very
Because
efficient students.
Because we were monitoring each case under TV monitor. Each step, as soon as there was a runaway X-rays or something, we took over.
No sunset syndrome like this.
No.
Subluxated IOL.
No, sir.
Nothing.
Nothing.
Extent. Extraordinary.
Okay, thank you.
Thank you.
Now I will call our next speaker, Dr. Prakash Kumar Kesha. He will be going to present Association of Peripapillary Nerve Fiber Layers, OCT finding in axial myopia.
A very warm good morning to all. First of all, I would like to thank Scientific Committee for giving me the opportunity to speak on the topic, a cross-sectional observational study on prevalence and OCT findings of macula and peripapillary nerve fiber layer in axial myopes at a tertiary care center in Eastern Bihar. It is a cross-sectional study, so no intervention was done, and it was done between the time period of December 2020 to December 2022. It is done to investigate whether there is any relation of peripapillary retinal nerve fiber layer thickness with axial length of myopic eye. According to histological studies, the retina becomes atrophic and degenerates in myopic eyes, particularly at the posterior pole, and these changes are associated with the high frequency of macular abnormalities. Data such as age, gender, and refractive errors grades were considered for analysis to correlate the OCT changes found at tertiary medical care center in Eastern Bihar with the changes found in different parts of the world. Continuous axial elongation of the eye leads to the overstretching of outer coats, causing various pathological changes. Because of extreme retinal thinning and chorioretinal changes in these persons, simple fundus examination may miss subtle retinal pathologies. OCT is an accurate tool which can localize such anatomical changes. It seems to be the paraclinical test of choice for highly myopic eyes. Our aim and objective of this study is to compare the incidence of axial myopia in 12 to 35 years old age group and to assess and quantify the degree of changes in thickness of retinal nerve fiber layer of macula and peripapillary through OCT. Materials used in this study is 100 healthy myopic eyes of 68 patients, and the instrument used is SD, that is spectral domain optical coherence tomography. Other than that, spherical error, cylindrical error, and IOP was measured. The cross-sectional study has been conducted at the Department of Ophthalmology, Jawaharlal Nehru Medical College Hospital, Bhagalpur, Bihar. OCT provides information not readily available by the conventional imaging techniques or fundus examination. OCT has enhanced our understanding of changes in different ocular layers when axial myopia progresses and the globe is stretched. These findings consist of dehiscence of retinal layers known as retinocysts, paravascular inner retinal cleavage cysts, and lamellar holes, etc. And these are some specification of the instrument used, like scan speed of 50,000 A scans, lateral resolution 20 microns, in-depth resolution 6, and power input is 90 to 100 ampere with frequency of 50 to 60 hertz. All eyes have a best corrected visual acuity of more than equal to 6/9 with normal anterior chamber and normal retina on slit lamp examination and fundus photography. Subjects with an abnormal appearing optic disc or a RNFL defect were excluded after careful review of the optic disc. Eyes with retinal pathology such as epiretinal membrane or rarely diabetic retinopathy were also excluded. Eyes with history of refractive surgeries, intraocular surgery, retinal laser therapy at the initial workup was done and underwent. If any such procedure was underwent, then it also were excluded. Eyes were divided into 3 groups for my study based on the level of baseline spherical equivalent, that is low myopic, moderately, and high. In low, 0 diopter to 3 diopter, and in moderate, more than 3 diopter to less than equal to 6 diopter, and in high, more than 6 diopter of power, spherical equivalent power. Source is the patient attending OPD in our hospital. Inclusion criteria is 12 to 35 years old and -3 to 20 diopter myopic patients have been included with axial length of more than 24 millimeter. Exclusion criteria Patients having myopia other than axial type is also excluded. Any lenticular opacity, any aqueous or vitreous opacity, any retinal pathologies, any choroidal or any other pathological finding were excluded. Most commonly, myopia begins in the age of 7 to 10 years and is bilateral and progressive until late adolescence. Myopia is that form of refractive error where parallel rays of light comes to focus in front of the sentinel layer of the retina when eye is at rest. Pathological myopia is that in which is accompanied by degenerative changes occurring particularly in the posterior segment of the globe. It is usually but not invariably associated with lengthening of the anterior posterior axis of the eyeball and is usually but by no means always progressive. It is probable that to some extent at any rate the myopia and the degenerative changes are independent but are usually closely related. Although there is a fairly close association between the higher degree of myopia and the complications to be referred to in this study, the nature of connection is yet to be fully understood as there is no definite parallelism between the severity of these changes and the degree of myopia, and it is not unusual for these complications to appear at a long interval after the onset of refractive error and to advance long after the myopia has come to a halt.
Can you conclude?
Yes, ma'am.
Prakash?
Yes, ma'am. This is in low myopic patient. There is a strong relation. RNFL thickness decreases with the increase in axial length, but changes are not even relative to the spherical equivalent of myopia. Myopic axial elongation may subject to retinal nerve fiber to tensile stress, which may eventually damage the retinal nerve fibers and reduce RNFL thickness. There are some limitations in our study. Our population consists of normal subjects. All eyes with abnormally appearing optic disc were excluded. However, our participants may not represent the normal population. That's why it is also a limitation. RNFL thickness values may be different in different ethnic groups and races. No baseline RNFL thickness measurement is done. It is not tested whether refractive error causes physiological thinning or not. If it causes, then what is its rate of thinning is not done as it is a cross-sectional study. There is no conflict of interest in this study, and I am thankful to our Jawaharlal Nehru Medical College Hospital. Thank you.
Thank you, Dr. Keshav. Very nice presentation.
Can you please summarize the purpose of the aim of your study?
Yes, ma'am.
And your conclusion in just one line?
Ma'am, to correlate the RNFL thickness, if it progresses more deteriorate with the axial length of the myopia, then there is a chance of we can intervene if there is more rate of change of RNFL thickness.
I mean, progression of myopia, you are trying to correlate with the OCT findings,
yes,
OCT
with the
RNFL findings.
So that we can try to limit or to intervene with our...
At the right time.
Yes, sir. Yes, ma'am.
So, was there any positive correlation, any conclusive positive correlation?
Yes, ma'am. There was correlation. If the myopia was with less than 3 diopter, then the thickness was not much less than the normal one. But if it is more than -4 or -6, then there is generalized average thickness is reduced to -92 micron, which is generally 102 micron in normal study, normal population.
Okay.
Okay. Thank you.
Thank you, ma'am.
Now I will call our next speaker, Dr. Kirandeep Kaur. She will be going to present the multicentric survey of hesitancy and motivational factors for COVID-19 vaccination among patients.
Good morning, one and all. I'll start here. Good morning, everyone present here. So I'll be presenting my study on hesitancy and motivational factors for COVID-19 vaccination among patients who attended eye care hospitals. I have no conflicts of interest to declare. So we all know there was a significant reduction in mortality and morbidity before and post vaccination for COVID-19. So in India presently only 390 million people have received double vaccination. Though these numbers look impressive, but we need to realize that these numbers are from a country with a population of 1.36 billion. So there are several factors which hamper the vaccination drive. A survey in United States of America revealed the vaccination hesitancy to be as high as 27%. So we did a study in a cross-sectional manner, which was a questionnaire-based study. The patients were telephonically asked questions by trained study coordinators in the month of June 2021. So there were a total of 36 questions divided into 5 sections focused on patient demographic, health status, awareness about the vaccination, the hesitancy and acceptance factors, and general perception about the vaccine. So the study was conducted in 6 tertiary eye care hospitals and 1 secondary eye hospital in South India. Patients aged over 18 years and who were able to understand the local language were included. The exclusion criteria was patient who denied participation in the study with no personal mobile phones, with any hearing problems, those who presented with any emergency ocular condition, or those who were systemically unfit. So at the time of the study, 11.2% of the patients gave history of previous infection with COVID-19, and there was a history of 20% of COVID-19 in one of their close family members. The risk perception for getting infection was present in less than 50% of the cases. We need to realize that this data is coming from the time when COVID-19 was at its peak in our country. And 44.2% of the patients were vaccinated against COVID-19 at that time. We noticed that the acceptance for vaccination was better in the elder age group. Males were 50% vaccinated in comparison to only 38% of females. And the vaccination acceptance was better among the higher income groups. It was also better with the more educational background and people who were coming from the urban areas. So the most important motivational factor we found in our study was the fear of getting infected or infecting any of the family members. 28% believed in the safety and efficacy of the vaccine. Another 12% got vaccinated because they were motivated either through the social media or family or friends. 6% got themselves vaccinated as it was mandatory by their employer, and then there were other few motivational factors. The most important hesitancy factor was the fear of side effects post-vaccination. That was in 17% of the study population. 13% gave history of prior vaccine-related side effect, because of which they were afraid of getting themselves vaccinated. 13% had systemic comorbidities. Around 15% believed that vaccines were not effective and safe for them, so they were hesitant in getting vaccinated. So 77.2% of the population felt that the vaccines have been sufficiently tested and are safe for human use. Only 56% of the population was aware that even post-vaccination they can get infected with COVID-19. 72% denied any bad experience post-vaccination. 75% of the patients believe that sufficient information is available related to vaccination to the public, general public, and 82% agreed that once the vaccination is made compulsory by the government, that only will help in the vaccination drive and eliminating COVID-19. So the most important hesitancy factor noted in our study was the fear of side effects post-vaccination, and this has been similar to studies reported from Israel and Portugal. The most important motivational factor was the fear of getting infected or infecting any of the family members, and the similar results have been published from United Kingdoms as well. So we found that the lower vaccination rates were associated with younger age, female gender, rural residents, lower income, and lower educational background. The limitations of our study were that the statements given by the patients were self-reported, and there was no proof check regarding the vaccination status, and we did not differentiate between a single and double dose of vaccination. Further, the improved acceptance among elder age group, it could be related to the government policy of earlier availability to that age group. The strengths of our study were a large sample size of 5,033, the multicentric nature of the study, and we believe eye care patients can represent the general population from tertiary centers. To conclude, we need to create awareness about minor side effects and need to allay the patient's fear to improve the vaccine acceptance. The fear of contracting the disease needs to be utilized to drive the vaccination campaign, and we particularly need to focus on women, people from lower socioeconomic status, lower educational background, and from rural areas, to improve any vaccine acceptance or per se any new intervention which we want to do as community ophthalmologists. Thank you.
Thank you. Thank you, Dr. Kirandeep. But I was surprised in this beautiful morning. Why are you interested in being a community ophthalmologist, just to highlight about this COVID vaccination?
Sir, because as ophthalmologists, like we will be doing, actually we go into community, so we need to, through this study, it is not only about the COVID vaccination, we get to understand about many factors which might be creating hesitance among the general public whenever we want to do any intervention or we want to bring something new. So there might be a lot of hesitancy among the general public. So this will help in understanding, like what we found the most important thing was the fear of side effects or complications. So we need to target that part particularly when we are going into the public area.
Each COVID vaccination certificate is now a must for getting admitted for eye surgery.
No sir, no it is not.
That's why I do surprise with this presentation.
Yeah, for an ophthalmologist, is it necessary to know it's vaccinated or not for nowadays?
Right
Presently it is not, ma'am. When we did the study at that time everything was stopped. So
You have, as a part of a doctor, you have gone to the society to know the awareness of the vaccination.
correct, correct. Not as an ophthalmologist, yes ma'am. Thank you.
Now we'll call our next speaker, Dr. Abhishek Kumar Sinha. He will be going to present on the topic smartphone imaging for optic disc changes in glaucoma, an important diagnostic tool.
So good morning everyone. My topic for today's presentation is smartphone imaging for optic disc changes in glaucoma. So as we all know, glaucoma is one of the leading causes of blindness worldwide, but its diagnosis remains a public health challenge, especially in developing country like ours. Community screening for glaucoma is becoming an important topic in ophthalmology given the long asymptomatic nature of the disease, which underpins the progressive loss of retinal ganglion fibers. Despite the fact that screening of glaucoma has not been standardized, the coherent principles are outlined and adapted according to the technical platform and socio-economic context. So we performed imaging of optic disc to explore its functionality to ascertain the optic disc changes in established glaucoma cases. Other glaucoma cases were invited to participate in the study and provided a written informed consent before retinal photography. Prior approval was obtained from DEC and study was conducted according with the tenets of Declaration of Helsinki. Patients who had hazy media making fundus evaluation difficult were excluded from the study. The requirements were a good camera phone with a good camera, a slit lamp biomicroscope and a 90D or 78D aspheric lens. So once the patient was selected, retinal photos were taken on Appaswamy Associates slit lamp using Google Pixel 4a and work 90D aspheric lens. Uncompressed photos were saved on cloud using inbuilt internet capabilities of the smartphone. So this is me trying to take the picture of the optic disc using 90D and this smartphone using a slit lamp biomicroscope. So this is the first pic. Patient followed up after 1 week or 2 weeks. So this is the second pic of the same patient being followed after a month. So this is the third pic. This is the fourth. This is the fifth. And this is just gonio imaging. If you can do with smartphone, you can also have. So advantages, it is cost effective, almost free. Follow-up is easy as taking pictures is the best method of documentation. Transfer and sharing of data is dead easy. Many software updates can be there with glaucoma, but photo documentation has long been there and will always be there as a very effective method to analyze optic disc changes. Disadvantages is time taking more than, it almost takes more than 10 minutes to focus both 90D and camera lens on the same plane, not possible in crowded wards and OPDs. It is very tiring procedure, I can assure you. Your hands would pain while holding the 90D lens horizontally in the air for long and just trying to focus it. It is a very cumbersome procedure and distorted pics consume time and add to patient discomfort. So these are the pics which come in between when I try to take the pictures. So it is not possible in each and every case and in crowded places. So coming to discussion, smartphones can also prove a useful diagnostic tool in ophthalmology. Smartphones with good camera quality is a simple, cost-effective tool for slit lamp biomicroscopic to determine the improvement or progression of optic disc changes at follow-up. It requires no special tools, but is very accurate in detecting subtle changes in optic disc morphology. Smartphone imaging can be utilized for almost every patient without adding to any cost. Benefits are numerous, but it also has its own limitations, as we have already discussed, and cannot compete with the very specialized instruments such as perimetry, FFA, OCT, or wide field fundus photography. So these are the references. Thank you.
Thank you, Abhishek. I think you have already described the limitations are more
Yes,
than
ma'am.
your advantages.
Yes, ma'am. Limitations are very much, ma'am. That is why, because it is very time taking, and the patient is almost irritated. In the end, if you try to take the picture over and over again, and he won't understand what's going on, because he's not accustomed to it now. That he.
Where are you working now?
Yeah.
So I am from Rio Rims, Ranchi. I am a junior resident there, sir.
Okay. Thank you.
Can you please specify one advantage of this tedious process for the clinician and for the patient?
In Rio Rims, Ranchi, where we live, ma'am, we are most of the patients which come are referred from the rural areas and tribal areas. So we try to explain the patient what changes have occurred. Most of the time we are unable to explain, and it is not possible to do fundus photography in each and every patient. So patients who tend to understand and they are ready to give time, I just show them that this is the change which is occurring. This is how I will show a normal disc. This is how a normal disc look, and this is what the change has occurred, and what will happen later on. So this is only the one thing that I can say, and it's an advantage because it's cost free and there's no additional cost. So the patient has come to OPD. If he is able to give time, we can go in the slit lamp room and take the photograph. And of course, he has to cooperate, ma'am. Otherwise, it's not possible, ma'am.
But glaucoma is all about progression,
Yes, ma'am.
isn't it? So
Yes,
saving of the data is equally
Yes,
important.
yes, ma'am.
If
Yes, ma'am.
if
Yes,
at
ma'am.
all
So-
it has to be of
Yes,
any
ma'am.
use.
Yes, ma'am. So follow up, we save it, ma'am. Internet capabilities of smartphone, we can save it on the Google Drive there itself. So there is no need to delay. Just we have to just make the auto backup on, and then we can just click the pics, and it will be automatically backed up on the drive and the folder you select. So it's there.
Okay. Thank you, Abhishek.
Thank you, ma'am.
Now I will call our next speaker, Dr. Rashmi Kumari. She will be going to present on topic, is tacrolimus an answer to VKC?
Good morning everyone. Myself Dr. Rashmi Kumari. Today I am going to present my paper on is tacrolimus 0.03% eye ointment an answer to VKC. There is no financial interest in this study. VKC is characterized by infiltration of conjunctiva by a variety of inflammatory cell types, especially eosinophils. VKC has previously been thought of an IgE-mediated disease, and several other immunological pathways have also been implicated. Patients with VKC have been shown to an increased number of activated CD4 T lymphocytes, predominantly T helper 2 cell, indicating that there is a hypersensitivity reaction to an unknown pathogen. Increased level of inflammatory cytokines, interleukin 3, 4, and 5 have also been demonstrated. Conjunctival papilla formation is related to fibroblast activation and production, whereas limbal conjunctival nodules are related to infiltration of inflammatory cells. The aim is to compare the efficacy of olopatadine 0.1% eye drop with tacrolimus 0.03% eye ointment in VKC, and to compare the tolerability and acceptability of above medications in VKC. Source of data is patient having VKC attending the outpatient department of ophthalmology NMCH Sasaram. Duration of study is between December 2019 to December 2021. This is a prospective observational double-blind study. Convenience sampling method by sampling method. All patients from either gender diagnosed as VKC with itching of variable severity and seasonal exacerbation and willingness to give informed consent and availability for regular blood included now in criteria. Exclusion criteria. Patient with acute systemic allergic manifestations like severe bronchial asthma, coexisting allergic rhinitis, on systemic therapy, any history of ocular herpes subjects who had used topical or systemic steroids, NSAIDs in the past 2 weeks, patient who lost follow-up, contact lens wearers, concurrent ocular disease, such a trial will be excluded, and planning to undergo ocular surgery during study period, all were excluded. HB percent, WBC, TCDC, absolute eosinophil count, a conjunctival swab cytology, all were lab investigation. Main preponderance was found in our study. Itching, redness, chemosis score were significantly reduced after follow-up, and the difference is significant between two groups. When we compare the mean lid edema score, watering and foreign body sensation score between group A and B, the difference is insignificant. Both drugs were equally safe and tolerable. In our study, mean age in group A and B were 12.75 and 12.63 respectively. In gender, there is no statistically significant difference was found in both groups. Medical treatment is preferred in acute phase of VKC, but surgical treatment were used only in severe cases. Disease remission with puberty suggests hormonal concentration. Itching score is equal in both the group. In our study, redness score decreased from baseline visit 1 to visit 2 and visit 3 and visit 4. At visit 3 and 4, there is a statistically significant difference in redness score. In our research, we found that in group A, the mean score decreases from 0.86 at baseline to 0.00 at the 4th visit, while in group B, the mean score decreases from 0.71 to 0.03 at the 4th visit. From this study, we can conclude that both olopatadine 0.1% eye drop once daily and tacrolimus 0.03% eye ointment daily are effective in reducing symptoms and signs of allergic conjunctivitis during 2nd and 4th week. An olopatadine 0.1% drop once daily is found to be more effective than tacrolimus 0.03% daily in reducing redness and itching score. However, the difference is not significant for lid edema and watering score. Thank you so much.
Thanks, Rashmi. So what is your take-home message? Will you start olopatadine or tacrolimus?
Olopatadine
is your drug of choice.
If itching is more, patient complaining of more itching and redness, then we'll give olopatadine most preferably.
Where are you working?
Sir, just past postgraduate, not now.
Just past postgraduate.
What is the place of your work?
Sasaram, Narayan Medical College.
Was there any associated disease with these VKC patients? Associated disease, intestinal elephantiasis, or any other nutritional diseases or anything like that? Have you looked for?
Sir is asking any systemic disease you look for in these patients?
Associated with VKC amongst the children?
Any allergic, other allergic disease like asthma?
You have not looked?
No.
Have you done this work by your own?
Yes,
or
sir.
you have collected the data from somebody else?
No, sir. I am only collected.
You have seen these patients?
In our college,
You have seen these patients of your study group?
Yes,
or
sir.
you have collected the data from someone?
No, sir, study group. For camp and some OPD patients, we collect.
Are you surprised?
See, follow-up is very difficult research question
Yes,
because
sir.
patients have to come regularly and they are not willing to come. Second thing is both olopatadine and tacrolimus. In case of severe allergy there, both are not going to work.
Yes, sir.
You have to add soft steroids like
Yes, sir.
lotipenol or promethanol, and then only the symptoms are going to relieve. So these are the things.
Okay, thanks,
Okay,
Rashmi.
thank you.
Now, I will call our next presentation. Yeah, Dr. Rashmi Kumari. I think same has been printed twice, yeah? Our next speaker, Vansa Bandil. Yasha Bandil. Okay. She will be going to present an ocular manifestation of seronegative spondylolithiasis pathies.
Good morning, everyone. I am Dr. Yasha Bandil from Shamsha Medical College, Jiva. I am here going to present my topic on ocular manifestations of various spondyloarthropathies.
15, 1, 5.
Introduction. Seronegative spondyloarthropathies are a group of disease consisting of ankylosing spondylitis, psoriatic arthritis, reactive arthritis, inflammatory bowel diseases, associated arthritis, and undifferentiated spondyloarthropathy. Although spondyloarthropathy is primarily a musculoskeletal condition, ocular involvement is an important clinical feature since it is considered either a complication or an associated disease manifestation. Ocular inflammatory disease are a common manifestation of these spondyloarthropathies, uveitis being the most common extra-articular manifestation, most commonly occurring in ankylosing spondylitis. Uveitis and spondyloarthritis is anterior, non-granulomatous, and unilateral, recurrences being fairly common. Other ocular manifestations of spondyloarthropathies are dry eye, episcleritis, and rarely scleritis. Uveitis, the most common manifestation, is usually sudden in onset, typically presenting with photophobia, redness, pain, and defective vision. Idiopathic AS and RS HLA-B27 related uveitis occurs more commonly in white men between the 3rd and 5th decades of life, but women and other races and age groups can also be affected. One of the hallmarks of acute anterior uveitis associated with AS or RS is that both eyes are rarely affected at the same time. Although the clinical course of uveitis associated with IBD can be indistinguishable from AS or RS associated uveitis, it is more frequently bilateral, chronic, and HLA-B27 negative, involving both the anterior and posterior segments of the eye more often. Uveitis associated with psoriatic arthritis or spondylitis is frequently accompanied by conjunctivitis, dry eye or keratitis, and may be indistinguishable from AS-related uveitis, but is less well characterized and often follows a chronic course or presents as acute bilateral uveitis. Because the prevalence of psoriasis is very high in general population, one should be cautious and not automatically establish an etiologic relationship between cutaneous psoriasis and any given type of uveitis. The exact pathogenesis of SPA as well as uveitis remains to date unknown. However, there seems to be close links between the two diseases, which occur due to the interaction of a specific, mostly shared genetic background, HLA-B27, external influences such as microbiome, bacterial infection, or mechanical stress, and activation of the immune system resulting in inflammation. Materials and methods. This is an hospital-based cross-section observational study. The study was conducted over 6 months from April 2021 to September 2021. Patients with a definitive diagnosis of spondyloarthropathy attending the Department of Orthopedics and Ophthalmology outpatient clinics, SGMH Sanjay Gandhi Medical Hospital, Rewa, were screened from eligibility in the study. Children less than 18 years of age, patients with previous ocular trauma, surgery, or laser procedure in the eye, patients with any other known uveitic entities like Fuchs, heterochromic iridocyclitis, Portner-Schlossman syndrome, patients with any other ocular or systemic disease other than spondyloarthropathy, which may be associated with or masquerade as uveitis, was excluded from the study. The diagnosis of spondyloarthropathy in each case was made as per the assessment of spondyloarthritis International Society criteria, which includes inflammatory back pain, which is insidious in onset, pain at night, and improvement upon getting up, age at onset less than 40 years, improvement with exercise, no improvement with rest for spondyloarthritis by a physician in the department. Patients were enrolled in the study after taking informed consent. All patients had a detailed history of ophthalmological evaluation to look for ocular manifestations of SPA. They were examined using slit lamp biomicroscope, ophthalmoscope, and tear film tests. The type of uveitis and their characteristics were defined as per the standardization of uveitis nomenclature working group criteria. Diagnosis of uveitis was made if grade 0.5 plus or more cells in the anterior chamber and fresh keratic precipitates were present, along with one or more of the following signs: circumcorneal congestion, hypopyon, posterior synecdoche, peripheral anti-synovial vitreous sage, and cells, active inflammatory lesions in the retina or choroid. Diagnosis of inactive uveitis past episode was made if grade 0 cells in the anterior chamber, pigmented keratic precipitates or pigments on the corneal endothelium, and pigments on the anterior lens capsule were present, along with one or more of the following: posterior synecdoche, peripheral anterior synecdoche on gonoscopy, collateral scar suggestive of old inflammatory lesions in the retina, and history of previous episode of pain in the eye with redness, photophobia, and blurring of vision. Diagnosis of episcleritis was made when there is evident congestion of episcleral vessel blanching with 2.5% phenylephrine differentiate conjunctivitis from the episcleritis. Diagnosis of scleritis was made when there is congestion of scleral plexus of vessels blanching with 10% phenylephrine differentiate episcleritis from scleritis. In patients who were diagnosed with uveitis, the characteristic feature and complication of uveitis were recorded. Observations and results. Distribution of cases according to the age of the patient. The above table shows the distribution of cases. It was observed that majority of the cases were in the aged between 30 and 39 years of age group. Distribution of cases according to, there was a male preponderance with 17% out of 17 cases out of 24 being male. Distribution of cases according to the type of spondyloarthropathy, the most of the cases, like 13 cases out of 24, were ankylosing spondylitis patients. Distribution of cases according to duration of disease, most of the cases were between 2 to 10 years of age. Mean duration of disease was 5.74 years. Prevalence of uveitis. Out of the 5 seronegative spondyloarthropathies, we observed uveitis, 4 of uveitis cases in ankylosing spondylitis. And there was one dry eye case in ankylosing spondylitis and one in psoriatic arthritis. There was one episcleritis patient in ankylosing spondylitis. It was observed that almost half of the study population. The various manifestations of seronegative spondyloarthropathies include uveitis being the most common, followed by dry scleritis and yearly scleritis. Among these, uveitis, a potential sight-threatening complication, must be detected early and treated promptly to prevent irreversible loss of vision. The patients are usually asymptomatic as the manifestations are often subtle and easily missed. Uveitis may present with defective vision alone and no other symptoms of acute uveitis, and hence a high degree of suspicion is required for early diagnosis and prompt treatment.
Time is up.
Yeah, just need to confirm.
Is this your first presentation in any conference? Yes. You are resident
Yes.
in Rewa Medical College?
Yes.
Professor Pankaj Chaudhary is your HOD?
No, the HOD is Dr. Shashi Jain, ma'am, sir. He is professor.
Have you shown your slides to your professors or teachers before presentation here? Such a crowded slide and others? Who will go through? If you are just presenting this paper as if you are just reading on your own. This is my suggestion from next presentations. You should prepare the slide, consult with your teachers and make some rehearsal at your house. Just go through like a book. Okay, sir. Any question of yours? Very quickly, because we are all running very short of time.
Thank you, Dr. Yasha.
From the other competitive session or
Just, I will confirm any of the previous speaker who has missed this session or was absent earlier has come or not. Dr. Aditya Anand, Dr. Shweta Deshmukh, Dr. Tejaswini. No. Then I will call our winner of the first session, Dr. Prasanna Venkatesh Ramesh. Okay.
Good morning, Prasanna.
Good morning, sir.
He will be going to present on the topic 3D digital puzzle assembly for amplified learning.
Can I start, sir?
Yeah, sure.
Yeah, thank you for the opportunity. My paper is on 3D digital puzzle assembly for amplified learning, a comprehensive self-learning tactile toolkit. I have no financial disclosure. So when we see the theoretical framework of a concept, it has many limitations. So we can see that there is no single real structure in a textbook of a cavernous sinus, or when multiple textbooks are referred, there are so many different images of a same structure, be it the circle of Willis, a cavernous sinus, especially neuro-ophthalmic structures, even the ophthalmic structure of the eyeball as well. So we wanted to create a practical session which will facilitate critical teaching, thinking and a coping skill for a neophyte. So that we brought in 3D printing technology where we printed using 3D printing simple basic science structures like the circle of Willis in a puzzle manner, like a puzzle assembly, like an automobile engineer or like a computer science engineer, how they can assemble it and then learn structures like that. So this is a printed model of our cavernous sinus, the circle of Willis and the eyeball structures. We utilize the concept of the children's to improve their intellectual knowledge. We buy and give them puzzles so that it helps them to play and then also learn. Similarly, can we do the same thing in ophthalmology to benefit an anatomical tactile learning was the purpose. So we digitally reconstructed the anatomical module in Maya LT software. So we sat with the Cunningham's, Chaurasia and the anatomical books. We reconstructed the anatomy and we used the Cura software to do the 3D printing. Today 3D printing is done for so many things which is very hi-fi and very technical. We wanted to go to basic sciences. The structures that we cannot dissect or we are not dissecting nowadays are the neuroanatomical structures. So we wanted to apply it. So we went and made the three-dimensional structures in the digital software, the cavernous sinus, the circle of Willis, the other neuro-ophthalmic structures. The circle of Willis again, as you can see here, this is how we made the structures. And then once the structures were made, we used a FabXL printer or a FabX printer to print the 3D structures. So the materials used were the polylactic acid, and you can see the final model. I have brought the circle of Willis model in my hand. So this is the model of the 3D printed circle of Willis. Once the model is printed, we can see that we have also spray painted it as seen in this video. Depending on the structure color that you want to, you can actually do the painting as well. So this is the cavernous sinus model, which I have not bought obviously, but we have also printed that, and the eyeball structures are also printed. The unique feature of our model is we have used real-time structure mimicking as much as possible. The retina, you can see, it is as real as possible, and we want to make an ophthalmologist learn basic sciences in a much better way so that teaching is actually the focus for a pedagogical to avoid any cognitive distortion like mugging up. Our models have a unique feature. The retina is printed with thermopolyurethane material, and it is in 2 dimensions, and not only the color, the autofluorescence, the infrared of a normal image, a flecked retina, a fibrovascular band, a retinitis pigmentosa, and so on is printed. So far with first year postgraduates, 97 users have been used, and the satisfaction level of the classes when we use a 3-dimensional touch learning of tactile anatomical learning was evaluated, and the discrete variables were converted into continuous variables, and a pair t-test was used. Without this 3D and with the 3D learning, tactile learning, how did they really significantly feel it? It was statistically significant. Student satisfaction was much better when they feel there was a 3D puzzle assembly to touch, to learn, to see where the anterior communicating artery is or the posterior communicating artery is, to feel and insert and learn. The satisfaction without 3D classes were also fine, but it was definitely less than one which we use with 3D. And the model that you are seeing now, it is open access. You can go to meh.org.in, and this 3D model is available for free download, and you can get your own model from that printed in whichever 3D lab that you want to. The model creation is the tougher part which we have done, and we have given it open access for the fraternity and the community. So the polylactic acid and the thermopolyurethane material, as you can see, it is very cost effective. This model, my dear friends, is just 200 rupees it takes to print a circle of Willis. For the cavernous sinus, it is 200. For the eyeball, because of the complexity, it came up to 1000. It took 10 hours to print the circle of Willis model, 5 hours to print the cavernous sinus model, and 30 hours because of the complexity of the eyeball, it took 30 hours. So my dear friends, puzzle making when combined with 3D printing can evolve into a different level of tactile learning in the field of ophthalmology, especially for undergraduates and postgraduates, so that there doesn't need to be any mugged up, there doesn't need to be any cognitive distortion as to how each structures are, and this has been a game changer or will be a game changer in e-ophthalmology. So this is again another structure that we are working where the whole complex brain along with the cavernous sinus, circle of Willis and the other systems is one that we are recently working on. And I once again thank you for giving me the opportunity to present this. So this is my model.
Just one question, any plans of getting it patented?
Ma'am, patent has been filed February 24th last year, the provisional specification. This year, before the February 24th, we are filing the complete specification. Okay. But having said that, we have given the model free of cost, open access. From our own resource itself, we have disseminated the model. We don't, learning is passion, so we don't want to charge it as of now. So we are disseminating it online, open access, ma'am. But we have patented it.
Extremely noble and innovative, I would say.
Thank you.
Yeah, very good idea.
Excellent. You are still working in Pondicherry or in Coimbatore?
Sir, I did my post-graduation in Pondicherry, sir, for the last, and then I went to Coimbatore for 3 years. Now I'm in Trichy for past 5 years, sir. I'm a proper Trichy, Trichirapalli near Madurai. Trichy, sir, Trichy. Sir?
Attached with which institution?
Mahatma Eye Hospital Private Limited. It's a DNB institute, sir. We have, it's a teaching institute. I'm taking care of the DNB teaching there, along with the glaucoma department.
Last time when you
Yes, sir. Last year, sir. On AIOCMTC. Yes, sir.
Thank you, Prasanna.
Thank you.
Okay. I will thank our chairperson, Dr. Samantha sir, co-chairperson Parijat, I think he is absent, convener Dr. Rajiv sir, co-convener Dr. Nimmi. Thank you all. All the speakers, please come on stage.